Welcome to those of you who found your way, even though the freeway off-ramp was closed. So we're going to do a little bit of welcoming here and hope that people are able to be as smart as, or even somewhere in the neighborhood as smart as Dr. Budoff, who found his way despite the freeway closure. So is there anything, Dr. Budoff, you want me to transmit out, or our staff to transmit out to the lost sheep?
No, I think follow Waze or Google Maps.
So as usual, on the day of a public gathering, there's always something. And today there were more than our normal share of the something. So one of them is that we had a problem with our video camera. So RAND Corporation technical staff is videotaping this room right now. There's the video camera, but it only videos the podium and the slides. So a different format for today will be that the speaker will have to repeat what is said. And this early section of the tape will be cut out because today is going to be possibly turned into enduring online continuing medical education, because we had Dr. Budoff give this presentation in Sacramento up near the Capitol at our other group on Monday. And the physician in charge of chronic disease for the California Department of Public Health found the material so important that she is looking at various forms of leverage to get the information out broadly. There are only so many people that we can fit at RAND and who can make their way with freeway closures and crazy traffic down here. But I will just say that learning about the coronary calcium score in 2015 was somewhat of a life-changing experience for my family, which has a good deal of cardiovascular disease, and for many other families and friends related to the RightCare initiative. So most of the professionals that have heard about the coronary calcium scan have now made the effort to get theirs done, and some are very happy with their zero scores, which is the case for about 50% of people who get scanned. And some are taking very proactive action based on their positive calcium scores. So depending on how positive the calcium score is, it changes the treatment pathway. It is a triage tool. So for instance, in my personal group of friends, family, and colleagues, we have a few surprising zeros, and we have a few surprising very, very, very high and concerning scores among people who appear to be perfectly healthy athletes who live very clean lifestyles. So while our cultural messaging has been that if you lead a pristine lifestyle, you are likely to live longer, that is still true, but it does not overcome your genes. It can moderate your genes, and I shouldn't say too much more before we introduce our formal speaker, who is the chair of Preventive Cardiology for the University of California, Los Angeles. He has over 800 publications, dozens of book chapters and books, has received awards from all around the world, He is an international phenom, and it was very, it took a long time to get him scheduled to come give this presentation, even though he is local here in Los Angeles, because he travels internationally with this very, very important scientific information that I believe will change the trajectory of death from stroke and heart attacks and disability from those things. And on Monday, we gave him an award, which I will present to him again when we get our critical mass of people here later in the program, so don't let me forget to do that. So I just appreciate the efforts that you made to be here. And I want, by show of hands, to know how many people here know their coronary calcium score. And for those of you who don't know your calcium score, I'm guessing that, like the regional director of the Heart Association for the California Capital and so many others, after you hear the presentation, you'll be asking, where can I get the scan? Because it just is information that you can act on, and your actions can save your life and those of your family members. So we have some really special people here with us today. Not only do we have the world's probably #1 expert on the power of coronary calcium for predicting heart attack, stroke, cancer, and all-cause mortality. Hello. It's $150 a scan. It has the same amount of radiation as a mammogram, and it is now in the American Heart Association and the American College of Cardiology Association's guidelines to help guide a treatment pathway for patients. So without further ado, I'd like to introduce Dr. Matthew Budoff, Chair of Preventive Cardiology for the University of California, Los Angeles School of Medicine. Thank you, Matt.
Thank you very much, Hattie. Very kind introduction. So good to see some familiar faces and some new people. Hopefully this will be fairly new. A lot of the data has come out more recently over the past year or so. So a lot of this is relatively new information and grant support. So today, most practitioners are asked at least to use a risk calculator to take a patient and incorporate certain clinical variables, things like high blood pressure, their cohort, they smoke, their race and ethnicity, their cholesterol values, yes, no for diabetes, and decide what their risk is, or come up with an estimate of their risk. The problem with these risk calculators is they grossly overestimate risk. It's probably the worst calibrated risk calculator we've ever had. They are supposed to be better because they are calibrated to race and ethnicity now. They're supposed to be calibrated based on different cohorts of patients in the United States, but when we test it in the real world against patients, it grossly overestimates risk. And the problem with that is that means you're going to grossly overtreat patients. When patients perceive that they may be overtreated, they don't want to take the therapy anymore. So the most important facet that I always teach my residents and fellows is that you can't make an asymptomatic person feel better, but you can make an asymptomatic person feel worse. So if we give them statins, and we make them go to the pharmacy 12 times a year and take a pill 365 days a year with some limited but some known side effects and concerns, that they're not going to stay on therapy. So not taking the pill then defeats the entire purpose. So we're treating the wrong people and compliance is poor. So it's a huge public health problem.
I'm sorry to ask you to pause on this slide. I really don't understand what the blue and the orange are.
I haven't explained the slide yet.
Okay.
So let me explain the slide first, and then we'll see if you have any questions. I didn't get to the slide yet. Sorry, I was just introducing the concept. So this slide represents the what the estimated risk should be. So this is 307,000 primary care patients in Northern California. This is what the risk calculator said their event rate would be. So that's their event rate. They did it over 5 years because they had actual data over 5 years. So this would be a high-risk group, 8% of events over 5 years. That's their risk calculation. In blue is what actually happened. So in blue is what happened to the patient. So that's the number of events that they had overall in this very, very, very large cohort. So they had less than 2% of patients had an event. It was estimated that almost 9% of patients should have had an event. So that overestimation is about 450%. In other words, the risk calculator said you're high risk, when in reality, they were low risk. So it didn't work very well in the high risk cohort. What about the intermediate risk cohorts, these two groups? Well, it predicted that you would have about a 4% event rate. They have less than a 1% event rate. So again, more than 400% overestimating risk. Same thing here, 500% and 500%. So it's probably can't do worse than this if you just randomly just told people you're going to have an event, you're not going to have an event, you're going to have an event, you're not going to have an event. I mean, honestly, this is just horrible risk prediction and gross overestimation. You didn't underpredict risk, you overestimated risk. So the risk predictors, as we know them, are based on populations of patients. They're based on tens of thousands of patients or hundreds of thousands of patients. And we take all these variables and say, well, based on a lot of people like you, your risk is X or Y. And that's very non-personalized medicine. That's population-based medicine. And it's not great when you actually apply it to the person. So we've been working for now since 1990, so almost 30 years, on identifying a way of identifying personalized risk. In other words, what is really going on in your coronaries? And this is not a new concept. In the 1600s, a scientist named Sydenham said a man is as old as his coronaries. And basically the concept was if your coronaries are all blocked up and full of, back in those days, hard rocks that they called atherosclerosis, you're going to die young. And if your arteries were clean and you had the arteries of a young man, then you're going to live longer. And obviously, I think that applies to women as well, although in the 1600s, a little more of a misogynistic society. So, so the 2018 guidelines for cholesterol, for the first time, now started to embrace this concept that we can do better with the coronary calcium scan, that we can improve upon this gross population-based way of risk assessing people and really refine it to a point where we can do better for our patients, getting the right people on the right therapies. So the new cholesterol guidelines advocate, and I'll show you the guidelines in a moment, but they advocate for more therapy with a calcium score above 100 and less therapy for a calcium score of 0, which aligns with our risk. And I'll show you the calcium score. This slide deck also got changed. Anyway, you have a picture of the iceberg, at least did a few days ago. Sorry, it's here. Sorry, having communication problems, I guess, with RightCare to get the right deck here. My fault. Anyway, so basically the calcium score, to back up a step, we don't have a slide on it, but the calcium score is basically the tip of the atherosclerotic iceberg. If you think about types of plaque that people have in their coronary arteries, about 20% is calcified and about 80% is not calcified. It's soft plaque or non-calcified plaque. And when we look at the scan, when we do a calcium scan, patients lay on the table, dressed as they are, flat on their back, and it takes a bunch of images. There's no needles, there's no IV. We hook up people to an EKG lead just so we can time it to the heartbeat, so we can get better, clearer data. But a very simple test. The whole test takes about 30 seconds. Low radiation. It's about the same as a mammogram. My boss, back in 1990, when he introduced me to the test, when I was just an intern at Harvard, UCLA, told me that it's the mammogram of the heart. It's going to tell us who we need to concentrate on for heart disease, who's clear and we don't need to worry about for the near future, and then they can get another mammogram of the heart down the road if they want to see what's changing over time. So it's about the same radiation dose as a mammogram as well. And actually, interestingly, Medicare, at least in California, pays the exact same amount as a mammogram for reimbursement. So, so in many ways, it is the mammogram of the heart, both from a cost, reimbursement, and screening type of perspective. Just looking for a different disease now, not looking for breast cancer, looking for heart disease. The score you get is 0, meaning there's no calcified plaque, and generally that would mean you have no or very little plaque in total. So it is possible to have a little bit of soft plaque, but that's unlikely to build up to the point of a blockage in a coronary artery or enough to cause a heart attack or a stroke. So a 0 score is excellent. And then the rest of it is just the volume. So the more calcified plaque you have in your coronaries, the worse the plaque is and the bigger the problem is. So we have this calcium score that gives us a number, 0 being great, we call that the power of 0, and greater than 100 is generally considered high risk. And it was built into the risk calculator, into the treatment. This is from the 2018 guidelines. And they basically said if you're in these two groups, which is about 50% of Americans, if you're in these two groups of borderline risk, 5 to 7.5% 10-year risk, or 7.5 to 20% risk, that the risk decision is uncertain to consider measuring a calcium score. 0 confers low risk, no statin. Calcium score 1 to 100 favors a statin, and calcium score of 100 or more initiates statin therapy. So we have this algorithm of care that is now extended. Again, and the arrows on the last slide were wrong, because in intermediate risk or selected borderline risk adults, it's reasonable to use a calcium score. So they built this into the algorithm of care in 2018. And the American Heart Association made a big deal about this. They had press releases just about it. This was published the same day as a press release from AHA on the day that the new guidelines came out for cholesterol guidelines. Coronary calcium tests could help clarify heart disease risk and control cholesterol. So we think that it's going to help us match intensity of therapy with intensity of risk. Oh, here's the slide that was, I thought, earlier. So the calcium score, again, represents about 20% of the plaque. So if you think about the iceberg analogy, when the Titanic was going downstream, when it saw a big iceberg off its bow, it did not send divers below the surface of the water to say, I wonder if there's something going on that could rip the hull. It knew there was a problem. When we see a lot of coronary calcium, we know there's a lot of problem, and we know there's a lot of that soft and vulnerable plaque in play. And if there's no coronary calcium and there's no icebergs, then the coast is clear. And the AHA-ACC guidelines, just to back up a second, say it's reasonable to withhold statin therapy and reassess in 5 to 10 years. I think 10 is a long time, but that's the recommendation, is to do another calcium score in 5 to 10 years. I advocate 5 years because I think as we get older, things change. We develop high blood pressure, our cholesterol goes up, we might develop diabetes, so there's other risk factors that can play a role. We did a study called MESA, the multi-ethnic study of atherosclerosis. And in MESA, the study looked at a lot of different ways of risk categorizing. So FRS is Framingham Risk Score. This is the traditional risk calculator. And then we tried to add other things to the risk calculator to try to see how we can do with reclassifying patients from intermediate risk to high risk or intermediate risk to low risk. And when you look at this, brachial artery testing did a terrible job. It reclassified 2% of patients, meaning you have to treat 50 people to move one person, test 50 people to move one person. Ankle brachial index was also miserable. C-reactive protein was terrible. Family history was better, and a lot of doctors like family history. It's free to acquire. It moved about 1 out of 6 people correctly upward or downward, but not part of our risk calculators because it doesn't add as much value as they would like. Carotid testing, a lot of people used to start doing carotid testing. I know there's some mobile scanners running around doing carotid testing. It didn't do a very good job, and that's now a class 3. Should not be performed in a symptomatic person recommendation by the American College of Cardiology and American Heart Association. They say it may be harmful. And the reason carotid testing may be harmful is not because ultrasound is dangerous. It doesn't cause any direct harm. But it misclassifies people so dramatically. Oh, you're high risk. Then you get another test the next day, and it comes out normal. So now you're low risk. And obviously your risk doesn't change from day to day. The acquisition of it is very, very tenuous. It didn't do a very good job of reclassifying patients. But in MESA, adding the calcium score, reclassified 66% of patients. That means for every 3 people who got a scan, 2 of them were told, oh no, you're not intermediate risk, you're high risk, or you're low risk. And when you look at the guidelines as, bless you, as they're written now, the Europeans, the United Kingdom, and the American College of Cardiology, American Heart Association have all given coronary calcium at least a class 2A recommendation, saying that it is useful. It's not mandatory, that would be a class 1 indication, but it is useful for risk assessment. And they say, and this is just a summary of all of the different guidelines. Quantification of calcium improves stratification between subjects at high versus low risk for coronary events, helping match intensified risk factor modification. In other words, we can go up on the statin or add some blood pressure control or put on an aspirin tablet to plaque burden, as well as actual risk, while avoiding therapies in subjects with low scores that have a low to 10-year event rate. In other words, avoiding statins like the new ACC guidelines advocate for 5 to 10 years with a score of 0. So most people think, well, if I'm going to do a scan, everybody's going to be reclassified to high risk. Now I'm going to find a lot of plaque and move people up. But in reality, that's not what we find. Over 50% of patients that we scan at almost any age group, obviously less than the very old, but in almost any age group, 50% at least have scores of 0. And 0 invokes a very, very low risk. So this is in another big population-based study called the Heinz-Nixdorf trial run in Germany. They took all the people in the intermediate risk category and they scanned them. And this is actually based on events. What happened, 14% of patients actually had scores of above 100. So about 1/7 of patients had higher scores and were deemed to be high risk. But interestingly, 2/3 of patients were deemed to have 0 scores in this intermediate risk category. So we de-risk more patients than we increase, which correlates exactly with the gross overestimation of the risk calculator. If you say that the risk calculator is coming up with too many positives, too many high risks, then you need a test that's going to put them into their proper category. And we move 2/3 of people back down into low risk, which is where they actually are. That's what they actually events occur. So it's very, very good to save healthcare dollars. I'll show you some cost savings. It actually saves more money than it costs when you do cost effectiveness, because these patients do not need a treadmill, a nuclear, a stress echo, a cardiac cath. They do not need statins as per the cholesterol guidelines that are signed on by 18 organizations. A score of 0 does not warrant cholesterol therapy for 5 to 10 years. So we can save healthcare dollars by implementing the calcium score based on what we call the power of zero. This is from the multi-ethnic study. Calcium scores of 0, 1 to 100, 100 to 300, and greater than 300. And these are just categories that we've created over time to make it easier for clinicians to know what to do with this data. Score of 0, reinforce good lifestyle. Obviously, we don't want them smoking. We want them to exercise. We want them to eat right. It's not a free pass that they're never going to get heart disease, but their chance of having an event over the next 5 years approaches 0%. Literally, you have a patient with a score of 0 over the age of 40 that had a cardiovascular event, and we can probably write it up in a journal. That's how unusual that event would be. That's the case report. You have a calcium score that's positive. Now they have a little bit of plaque. Their risk goes up fourfold. They're at higher risk, but they're still overall low risk. When they break 100, they are at 10 times. That's a 10-fold increased risk of having an event with a score above 100. And more plaque, more risk. Those people with a lot of plaque, what we call severe plaque burden, had 14 times the number of events. So we can, in the first 5 years especially, virtually guarantee what's going to happen based on the calcium score. I did a 10-year study from that multi-ethnic study of atherosclerosis, and we looked at all different subgroups, different racial subgroups, men, women, older, younger. I'll just blow up one of the subgroups. This is the Caucasian population. A score of 0 over 12 years. This is 7.5% risk. This would be low risk. This would be borderline low risk. They are well below borderline low risk with a score of 0 even after 12 years. So they are very low risk according to the guidelines if they have a score of 0 for the next decade. Again, I don't like to say let's wait 10 years because some of these patients are having some events. So I'd like to reassess at 5 years when the event rate is still very close to 0. Some of these patients' trajectory is a little bit higher, and they start to get high risk when their score is either above 100 or above 300. And as you'd expect, more plaque, more events. So very simple analysis. This worked in every cohort of patients. So a score of 100 is bad, whether you're a young African-American female or whether you're an old white male or anything in between. It's the plaque burden is bad and lack of plaque is good, regardless of who's walking around with it. So we can expand upon the name simple. A man is as old as his coronaries, so maybe a person is as old as his or her coronaries. So let's prove that over a long period of time and prove that we don't need to put patients on statins if their score is 0. And this is, I think, it's not a prospective, double-blind, placebo-controlled trial. This was long-term observational data, but it was in the scores of 0, it was over 8,000, almost 9,000 people followed for a full 12 years of follow-up. So very long follow-up in a very large number of patients. And in this graph right here, there are actually 2 lines. I can't see 2 lines even when I stare at the smaller screen. But there were 2 lines. There's a line in blue of what happened if patients were not taking a statin. And there's a line in red of what happens if they were taking a statin. And those 2 lines are so superimposed, there's not one, if you zoom in, there's not one space, any space between those lines ever. It was showing us that if you took statins for a decade, it would change your event rate by 0.0%. The hazard ratio literally was 1.00, meaning that being on a statin reduced your events by 0%. So the number needed to treat, if you said, well, I have a score of 0 and I want to put them on a statin anyway, the number needed to treat would be infinity. You'd have to treat an infinite number of people, and you still, based on 9,000 people with 12-year follow-up, have prevented 0% of events by using statins in that cohort. This came out a month after the ACCHA guidelines as a proof of concept that the guidelines were correct, that we can withhold statins, and in this case, they're right. You can withhold statins for a decade. based on a score of 0, and you're not gonna have missed any opportunity to prevent any events. If you look at the group with the 100 score, where they say you have to use or you definitely should use a statin, those two curves are dramatic. This represents a 68% reduction in cardiovascular events by putting a patient on a statin if they have a score above 100. 68% less events. Number needed to treat, you treat 12 people with a statin, one of them does not have a heart attack or die over the next decade. So question?
With the 0 to treat for infinity, what about the recommendation for diabetics to all be on statins?
Right. So that brings up a really good question. So the question is, what about the recommendation that even if they have a score of 0, diabetics should still be treated? And I think that's been proven a long time ago to be incorrect. The ACCHA guidelines that I was a co-author on in about probably 2013 said that diabetics with a score of 0 do not need to be on a statin, but the newest guidelines just put a little asterisk saying consider statin therapy if they have diabetes regardless. We have a subgroup they had in there. I don't have the slide here. In there, they did a subgroup of patients with diabetes, and the curves stayed the same. There's no benefit to putting a diabetic on a statin if their score is 0. So I think that goes back to our concern that diabetics generally are high risk, and we don't want to undermine our guidelines, but it's probably scientifically incorrect. I wrote a guideline from the American College of Cardiology just on diabetics, on asymptomatic diabetics, and we recommended that statins could be withheld, and that was an official policy of the ACC. But the ATA and some of the other diabetes groups were concerned of undertreating our diabetic population, but they played out exactly the same. And family history is another group that they say they have a strong family history. Maybe you shouldn't be so dogmatic about a score of 0. This is 7,000 scores of 0 followed for, again, about 12 years. That's their survival benefit if they didn't have a family history with a score of 0, 99.6%. In red is if they had a positive family history. Really didn't change the curve or the trajectory of the curve. They were very, very, very low risk if they had a positive family history and a score of 0. So I think we have good data in both diabetics and family history. The third group that they call out is smokers. And we just don't have as much longitudinal data, but that's probably a whole different process anyway. Smoking causes clots to form in the coronary arteries. So smoking is probably not as much an atherosclerotic event rate as it is a prothrombotic event rate. So I think I agree with these smokers because I think there's other things that can happen in that population. So the smoking is the third group that they call out saying, be careful about a score of 0 with diabetics, family history, or smokers. The first two are incorrect based on the science, but I think the recommendations are made to be conservative. So what about just going back to simple things like risk factors? So this is a large study. This is actual event rates. Now in yellow are scores of 0. And if you go from 0 risk factors over here, you get a very low event rate. And if you go across to 1 risk factor, 2 risk factors, 3 or more risk factors for heart disease. So these are diabetes, high blood pressure, high cholesterol, family history, smoking, and age. You can see that really the event rates stay very low. There's a slight bump up going from 0 risk factors to 3, but all of these patients at 3 per 1,000 or 0.3% are very low event rates. If you go the other way, this is going from a score of 0 to a score above 0 to a score above 100, even if they have no risk factors whatsoever. So they're, quote, low risk. Their risk goes up by 15-fold, a huge increase in their underlying risk. And if you, of course, go from high calcium score and you go from no risk factors to multiple risk factors, their risks go up. So the worst place to be is up here, a lot of events occurring. And this is multiple risk factors and a high calcium score. So there is synergy with both. you look across this way, the risk is pretty modest. If you look going this way, going up from 0 to 100, the risk is dramatic. This is high rises, and this is a 29-story building, and that's your first story house. And how high your risk goes by going up. And calcium score elevates the risk much, much more than numbers of risk factors. So we have and for anybody who wants, I'll be glad to share the slides with you afterwards. I'm glad you take photos, but I'll send my slide deck to anybody who'd like it. Yeah.
On that slide, does that take into account if you had high cholesterol and you were found to have a positive score and you went on a statin and you brought that risk factor down, are they
So this is just risk factor, yeah. So this doesn't account for treatment. So I was asking if you treated that risk factor, you would still be based on risk assessment guidelines. You still have the risk factor. You never don't have it. So we can control diabetes. We can put them on a statin. We can lower their blood pressure. They still have a cardiac risk factor. So this is just looking at the risk factors and not the effective treatment of those risk factors. We do have data on treatment in a moment. So this is a remarkable study looking at mortality for all different things based on the calcium score. And some of this could be a little bit age-related because atherosclerosis or coronary calcium scores are a little bit age-related, but this was a study done in a relatively middle-aged population, so it didn't have a huge age range. It wasn't like studying 20-year-olds and 90-year-olds across the spectrum. And those people in gray who had a huge calcium score, way high, severe, extensive, whatever terrible term you want to use for calcium everywhere and omnipresent, they had a 5-time increased risk of dying from heart disease, an 8-fold increased risk of dying from heart attack or stroke, a 5-fold increased risk of dying from cancer, and when you add them all together, they were 19 times more likely to just die from any cause. So the higher the calcium score, the worse off they do. And you can imagine there's going to be some interrelationship even with things like cancer. Calcium is not totally independent of what's going on in the rest of the body. It's the accumulation in the heart. But if you have a ongoing cancer, you have a lot of inflammation, and that probably can feed the calcium score and make it go up. So a high calcium score, even a modest calcium, this is severe, but a modest calcium score, still 10 times more likely to just be dead from all causes, including cancer, including stroke, including heart disease. So we have really good data now showing us that patients are, the more plaque they have, the worse they're going to do, and they deserve more therapy. The therapy now goes back to personalized medicine. What do I do in an individual? That would depend on their individual risk factors. For the person with diabetes, obviously I'm going to focus on diabetic control and getting them on a statin and getting them on other therapies. For a patient with hypertension, the treatment would probably be different. For patients who have a family history and their cholesterol is perfect and their blood pressure is perfect, maybe we have to think about other treatments. So it's all going to be individualized based on what we find, but knowing who's at high risk, knowing who's at high risk allows us to identify those patients. So this is a picture of the calcium score. And this shows us the plaque burden. Oh, thank you. Shows the plaque burden that we can see and the calcification. It's very, very easy. And I truly believe this is true, that a picture is worth 1,000 words. I think that patients can see their plaque, and that's your coronaries, not a theoretical. You know, they had these other ads like this is your lungs on cigarettes. They showed these terrible pictures, and that's all. Well, maybe those are mine, maybe those aren't going to be mine. I don't know. This is the person. When I sit down with them, and I show them their coronary arteries, and I say, look, you have plaque in the left anterior descending, the widowmaker. You have plaque in the circumflex, and I don't estimate the number. The computer scores the volume of calcified plaque and gives me an exact number, allowing for two things. One, I can stratify better. I can say, okay, your score is 270. that puts you at a certain age and gender risk. And I can follow that 270 over time. So when I go back to my ACCHA recommendations to retest in 5 years, I can say, oh, you used to have 270. Now you have 800, and it's a whole lot worse. So it gives me a way to track atherosclerosis non-invasively as well. So for me, it affords me both yes, no, you have the disease or you don't. More than half have no, they don't have the disease. But if they have the disease, I now get a number, and I can put that in context of age, gender, race, and ethnicity. And is it recording? Oh.
All right. Oh, I didn't touch the button, so.
Okay, Matt, we're just gonna have to have you do this. Someone else. We're gonna take you to San Diego.
Well, I thought you had a second camera.
Oh, bless you.
Ah,
Keith, you're a lifesaver.
I said, did you say you had 2 cameras running? Or, no?
Well, they're supposed to be multiple,
All right.
actually. This is such important information.
Well, anyway,
The camera didn't
yeah.
arrive, but it's
All right.
supposed to be here.
So, anyway, the concept is that we can now identify the amount of plaque in the coronary arteries over time, and we can really assess it, and we can show patients that picture. And once we do that, we know that we get great motivational effects from that, and that's been studied now in 17 different studies, including 2 prospective randomized trials where they got randomized to a calcium score or no calcium score to see if that impacted their behaviors. So one of them was done here in Los Angeles by Dr. Berman's group at Cedars-Sinai called the Eisner Study, sponsored by Mr. Eisner. 2,137 patients, asymptomatic, so middle-aged, asymptomatic people, randomized to a questionnaire and a consultation with a clinical nurse, or same thing, but also getting a scan. So after they had their risk factor consultation with a nurse, they then got a calcium scan, and then they adjusted what they did based on the scan. So you can imagine, oh, you have a lot of plaque. Before, your guideline said you may or may not need a cholesterol pill. Now I want to put you on a cholesterol pill. Or now I want to put you on aspirin, or I want to tighten up your blood pressure control. And it worked dramatically to lower the overall cardiovascular risk. Now, it's only 2,000 patients followed for 4 years, so it didn't have hard events in there like reduction in MI and stroke, but we did see the changes that occurred if they had a LDL, change in LDL cholesterol. It went down a little bit in the no-scan group because remember, this population saw a nurse and the nurse may have advocated, hey, your cholesterol is very high, you should be on a cholesterol pill. But it went down almost 3 times as much if they had that calcium score. Blood pressure went down twice as much. And I can promise you, if you apply a 4 millimeter mercury change to a large population, that's probably a 40% or 50% event reduction for stroke in that population. These numbers mean a lot, even though they're relatively small numbers for an individual. New lipid therapies tripled. New blood pressure therapies more than doubled. New aspirin therapies tripled. So all of the things that you might associate with atherosclerosis were being done much more frequently if they saw the scan than if they just saw the nurse and was told what to do. And finally, adherence. And this is not a few weeks later. It's not a New Year's resolution that I'm going to stay on my statin and stay on it for 4 weeks or 4 months. This is 4 years down the road, and it was significantly better if they had a calcium score versus if they did not. But the big question for healthcare providers is, well, at what cost? How much did this cost us to add a calcium score to get better outcomes? And it saved us money. It saved healthcare money because of the power of zero. In this trial, 60% of patients, middle age 45 to 80, 60% had scores of 0. meaning that they were told you don't need a treadmill, a nuclear, or a cath. You don't need to be on statins and maybe even aspirin or maybe more therapies. And we saved 37% of healthcare costs on follow-up tests that they might have gotten. A lot of these patients get screened. You can argue that's appropriate or inappropriate, but they get screened with a treadmill or in Cedars-Sinai, a stress nuclear, and they get put on statins, and now we could say they didn't need that. So we can save money with high confidence. We can save money with a p-value less than 0.005 that we're saving money by applying a calcium score. So it's not only helping us identify who's at high risk and hopefully saving lives, we also are saving dollars by using a calcium score. And part of the reason is the calcium score is inexpensive. It used to be expensive when the machine first came out. It was a $2 million piece of equipment. We can only do calcium scoring on it, so we used to charge about $400 per test. Now the average cost in Los Angeles is about $129, and in many states and many other cities, it's below $100. So the cost of the test has gone down dramatically. Medicare pays about $98 for the test in California. So what about heart failure? All the data I showed you so far is just about atherosclerotic heart disease, but it's kind of interesting. It also helps us identify patients with congestive heart failure, and that's becoming a huge issue, one, because it's a huge cost item, and two, because it's one of our most rapidly growing causes of morbidity and mortality, and it is the #1 reason why people get hospitalized in the Medicare population. And we know that calcium score was very good at telling us whether their heart failure was from a heart attack or not from a heart attack, but it also predicted who would develop heart failure. This is a study, a population-based study called the Rotterdam study. They studied 2,000 older individuals, and calcium scores were associated with heart failure with a hazard ratio of 4, meaning that those patients with a score above 400 were significantly more likely to develop congestive heart failure than those patients with a score of 0. Now, calcium is not going to be perfect for CHF because some of heart failure has nothing to do with coronary artery disease, but it is a majority of patients who develop heart failure do have ischemic or coronary disease as the cause of their heart failure. So this showed a nice prediction: no coronary calcium, low risk of heart failure. And as the calcium score went to less than 100 to more than 100 to more than 400, your risk of developing congestive heart failure over the next 7 years was about 4-fold increased. So it might give us further insights, and as we do cost effectiveness modeling, we probably want to build in the most expensive cost to our system to help us know that the calcium score of 0 is also telling us maybe they're going to not go down that road as frequently, and those positives we need to be even more aggressive with, because not only can they have a heart attack or a stroke, but they can get CHF.
So for the people in back here who can't read that bottom number, maybe you could just describe just a little bit more.
So, well, these are just follow-up in years. So this is 0, 2, 4, 6, and 8. So over about a 7-year average follow-up, these people were 4.1-fold more likely to develop heart failure. These are just a cumulative number of cases. They ended up with about 80 cases of heart failure among the 1,800 patients in this trial. And this, I think, this back then, this was 2012, probably represents reduced ejection fraction heart failure. HFpEF is also associated with coronary calcium preserved ejection fraction, does have an association with calcium. So I think we need to build better models for predicting heart failure. And we're doing that in big studies like MESA and like Framingham and like Rotterdam, but they're still working on some of those models. But it does help us predict who's going to develop congestive heart failure as well. Can we treat a person with a high calcium score and improve their outcome? And that's probably the most important question, and the question that unfortunately we have limited data with. And I'll explain why in a moment, but I'll show you the prospective randomized trial first. This trial was done in the late 90s and published in the early 2000s It's called the St. Francis Randomized Trial. And they took asymptomatic patients, men and women aged 50 to 70. That's kind of our target for screening. That's the intermediate risk or intermediate age population. They had to have a calcium score above the 80th percentile based on age and gender. So they individualized it. So a 50-year-old female with a score of 2 or 3 would qualify. A 70-year-old man would probably need a score of maybe 150 or 200 to qualify to be in the trial. And they randomized them to a statin or placebo. Now, first, before I get into the data, we're not trying to lower the calcium score. We're trying to lower their risk of having a heart attack or stroke or dying. And they lowered their risk of cardiac endpoints, heart attack, stroke, death, or revascularization by 30%, and heart attack and death by 44% by adding atorvastatin 20. Not even an aggressive statin, but back in the 90s, this was considered pretty aggressive treatment. Event rates were more significantly reduced in patients who had higher scores. And that's not surprising. The more calcium you have, the higher the risk, the higher the benefit. So the overall event reduction went from 30% to 42% reduction in MI, stroke, and death by being on a statin. So statins, we know. We can add a statin to a patient with a high calcium score. We're not going to lower the calcium score, we're going to lower their risk of dying or having a heart attack, which is the goal of the statin anyway. So some people have gotten this confused and said, well, the calcium score doesn't go down, so it's not a good test. And I'm not trying to get the calcium score down, because once it's there, it's plaque, it's embedded in the arteries, it's probably not going anywhere in any significant amount. But we can lower their risk of having a bad event. Now, I mentioned this was one of the last trials that we had, randomizing patients to atorvastatin versus placebo with a high calcium score, and that's because the NIH has deemed it unethical to take patients with elevated calcium scores and randomize them to a statin or no statin. So we can't do another trial, and we've tried to appeal to different groups to implement this. There is a new trial that's ongoing, that's starting now. You have a high calcium score and you get randomized to a PCSK9. Amgen is doing a trial called Vesalius, where we're taking patients with an elevated calcium score and putting them on Repatha versus placebo, and we're following them. Because Repatha is not considered, they're on a statin, but Repatha is not considered part of the standard of care, and we are able to do that randomization. So that trial is underway and is starting to enroll. And we should have data, but obviously that'll take 3 to 5 years to get outcome data. But we will have another trial. It just won't be with a statin. I'm hoping to also do this type of study with some of the new diabetic agents that have anti-atherosclerotic or cardiovascular risk protection over time. But we haven't started those trials yet either. But with a statin, we're not going to get more data. We might get from outside the U.S. Statins are not considered standard of care in every country outside the U.S. But I think in the United States, this trial that started in 1995 will be the last one that we see. So people have said, oh, I need more data. I want a second randomized trial. I want a larger, there's only 1,000 patients. I want a larger randomized trial. I've been to the NIH 4 times with 3 different groups. And every time they're interested, but then they deem that they're not going to fund it, or they don't think it's an ethical or randomization, so they won't let us proceed.
Could you just mention that they did fund your big, large MESA trial?
Yeah, so MESA is an observational study, but that was funded by the National Institutes of Health. The initial funding was about $63 million, and probably they've invested probably about $150 million by now, because they've continued to expand the length of the follow-up. So that was 7,000 patients, men and women, multiple ethnicities, African American, Hispanic, white, and Asian, were followed for now almost 20 years. And the only way that you can get into the trial, one of the entry criteria, you had to have gotten a calcium score. Of all the tests, it didn't matter if you didn't want to give them your social security number, if you didn't want to consent to getting a carotid test or a blood test. If you didn't get a calcium score, you weren't allowed in the trial. So the NIH had built it around, and this was a long time ago now, we're on 20-year follow-up, but in the year 2000, they said the test will be based on the calcium score to test how good a predictor it was. And we're still doing research on it. And I just got a new R01 to look at some other parts of MESA. So we're still getting funded to do more work on that cohort. And it is still ongoing, and the follow-up is ongoing. So it's kind of like a modern-day Framingham study. Framingham also has calcium scores, but in the offspring, because the original cohort is largely dead by now. So what about cost? And there's been a few cost effectiveness studies. This is one published in a pretty prestigious journal called PLOS One. The cost effectiveness of coronary calcium is robust due to better and more accurate targeting, in particular to statin and aspirin therapy, as well as promoting more adherence to those therapies. So we know that it passes muster based on cost effectiveness. And if you looked at something like basing it on a C-reactive protein, a biomarker, a blood test that measures inflammation, this is the CRP test. In the Jupiter study, they showed that if you put them on rosuvastatin, 20 milligrams, you lower cardiovascular events. But in the Jupiter study, this was a subgroup of patients from that we looked at the Jupiter population. Calcium score of 0 represented 47% of these patients. Again, that 50%. And the reason it's lower than 50 is because these patients had multiple risk factors and had elevated inflammation to get into the study. So they were kind of a select group, but still, you need to treat 549 people for 5 years. So that's like 2,600 patient years of treatment of rosuvastatin to prevent one event. And if they had a score of 100, you need to treat 24 people to prevent one event. So you bring 2,745 to about 120 people. So you want to cost effectively give out therapy. You want to be able to apply even who gets a statin. We can treat 24 people and prevent a heart attack or death, or we can treat 550 and put it in the water supply. And we know not only is this going to be better, but this doesn't even take into account compliance. And when you add in compliance of the calcium score and you get more people taking active therapy, those numbers probably get better as well, at least in models. What about aspirin? Aspirin is a huge problem right now. A lot of confusion, a lot of terrible aspirin studies that have been done. Honestly, they probably shouldn't even been published, though they're so bad, because the crossover rate was so high. So in a recent study in Europe, patients had they were put on aspirin or placebo, randomized. The crossover rate was almost 50%. Those patients who were supposed to be taking aspirin stopped, and those patients who were not supposed to be on aspirin ended up taking aspirin. So it just ended up being a mishmash of no benefit, and they said, oh, it was only a 4% reduction in risk. If you were randomized to the aspirin group versus placebo, aspirin doesn't work. But then they said, well, who's actually taking aspirin versus who is not taking aspirin? The reality, right? That's how we assess patients in my practice. If I write you a prescription for a drug and you don't take it and you have a bad outcome, I don't say, well, the drug failed. You failed to take the drug. So if you looked at people who took aspirin versus who did not, aspirin afforded a 47% reduction in heart attacks. 47% reduction in heart attacks if you took an aspirin in that trial versus if you did not. So aspirin, if you look at who's actually taking it versus who's not, is the best preventive therapy in the world. Nothing has hit 47% ever. Or, the way they publish the data, aspirin is useless. And you can conclude both of them from the same trial. So I'll contend that aspirin is confusing. It's everywhere. Patients are not on aspirin, but they have a stomach ache and they take Alka-Seltzer. Well, Alka-Seltzer has aspirin in it, so you're taking aspirin now. And if you take Alka-Seltzer twice a week, you're on active aspirin. You don't know it because you don't think of Alka-Seltzer as an aspirin tablet, but it is. So it's a problem because it's everywhere. It doesn't require a prescription. You can get it anywhere, and you get it sometimes when you don't even expect it. Excedrin is aspirin. I mean, there's a lot of drugs that people might take for migraines that they don't even know or might not think is really taking active aspirin, but they're on aspirin. So can we have a calcium score help us with this difficult problem of who to put on aspirin? Well, this is the number needed to harm. That red line represents how many people will have a GI bleed, will have a bad outcome based on a major GI bleed if they're on aspirin. And the number's about 400, little more than 400 people. If you treat 400 people with aspirin over 5 years, one of them will have a major GI bleed, and that's a bad outcome. If you took low-risk people and you put them on with a calcium score of 0, and you put them on an aspirin, you would have to treat over 2,000 people to prevent one event. So you would prevent one event for every 2,000, you would cause one event for every 400, and you'd be harming 5 times as many people as you're helping. So whenever these lines are above this line of identity, you're doing more harm than good. Look what happens when you get to a calcium score above 100. Whether you're deemed low risk by the Framingham or intermediate or high risk by the Framingham or the risk calculators that we use, you're about 5 times more likely to benefit from an aspirin than have a GI bleed. So I am very dogmatic in high-risk individuals, if they have any calcium, and in anybody with a calcium score above 100, that you will benefit more from being on that aspirin tablet, 81 milligrams, low dose, adult low dose, or what we used to call baby aspirin, as compared to your risk of bleeding. Obviously, we have to individualize that. Somebody has peptic ulcer disease or liver disease, we want to be careful. But in general, aspirin is an excellent way of delineating who would benefit from aspirin as well. So in my patients with a high score or a low score who are at high risk, this red group, they're diabetics or other groups of patients who are deemed high risk, but their calcium score is intermediate or low, I put them on a statin, I get their LDL under control, and I put them on an aspirin as part of my active prescriptions. Of course, lifestyle, very important, diet, exercise, all the rest, but at a minimum, aspirin and statin for my prescriptions that I write them. And we know that it works. We know that calcium improves delivery of these preventive therapies, matching the risk of the patient with the amount of therapy that we give them. And we know that this power of 0, that more than 50% of patients will have a 0 score, allowing us to avoid therapy in a large number of patients, which is probably more important now than knowing who to treat, maybe, is knowing who not to treat when we're talking about such large numbers. And it improves compliance. So these are the groups that we focus on. This is from a societal level, this is not my list, but these are from the Society of Cardiovascular CT and an ACC working group. Intermediate risk patients benefit the most. When our risk is uncertain, you're intermediate risk. Nobody's intermediate risk, right? If we knew long enough, if we had a good enough crystal ball, you're either going to have a heart attack or you will not. There's nobody in the middle. You're not partially pregnant. You're pregnant or you're not. So intermediate just means we don't know. We can identify and move a lot of these patients out of that gray zone into a yes or a no category, at least for the next 5 to 10 years. Family history, again, diabetes made the list, lower risk diabetics. Maybe this would be very, very helpful. If nothing else, I use it a lot in diabetics, not to hold back therapy, but to convince them that they need to be on therapy. Diabetes is a tough one. They're on a lot of pills already, right? The average diabetic has hypertension, so that's 2 pills. The average diabetic's on 2 or 3 diabetes meds, that's another 3. Now we're going to add aspirin and a statin, that's 7. That's without anything else going on in these patients, which they all have other problems because they got to diabetes by being overweight and not good exercisers and other healthcare issues. So I use it to help convince them that they do need to be on therapies. I say, look, you need to be on the statin. I know you don't think you don't want to take it. You're taking too many pills. So let's just get a calcium score. And if it's positive, then take the pill. If it's negative and you're correct, I'll leave you alone for 5 years. And they pay the $99 and I'm usually right and they need the drug, but Sometimes they're right and they don't need the drug, but either way, they believe it now because it's not just me saying, well, based on a whole bunch of other diabetics, you should be on a pill or you should not. It's based on your coronary arteries, you should be on a pill or not. Those same thing with reluctance or patients who are, quote, intolerant. A lot of more of those in Southern California than other places, probably not really intolerant, and they somehow are convinced to try one more time to take a statin when we show them they have a lot of plaque in their coronary arteries. So some of this intolerance goes away. Decisions for non-statin therapy, this is a big one. These drugs are still expensive. We talked about Vascepa, very cost effective, great therapy, reduces events by 25%, but that's a prescription medication and that requires a little more work and maybe we need some help deciding that. Certainly the PCSK9s, the injectable cholesterol medicines, even more expensive, about 3 times as much as Vascepa, and we need to make those decisions based on good data, especially in primary prevention where we might want to be aggressive, but we can't afford to be aggressive in everybody. Aspirin, as I talked about. Low risk chest pain, sometimes it helps. Somebody has some atypical, you really don't think it's anything. I do a calcium score, I say it's 0, I say you're fine, you're low risk. And I at least know they're low risk. I can't totally prove their coronaries are clean, but I know they're low risk of having anything bad happen. And of course, the best reason, get them to actually do what I tell them to do. So what about the flip side? Who shouldn't we treat? Well, this is very important. Younger patients, we've got to be careful. We have to remember that most patients age under 40 will not have a cardiovascular event over the next 5 years. But if we're trying to find those outliers, we either have to scan a whole lot of people or we need a better test. And I don't know, but calcium score is not that great in the very young. And if they have something wrong, it may not be atherosclerosis and show up as a calcium score. So under the age of 40, I'm nervous. Early onset diabetes, we've had some nice data. If they have type 2 diabetes starting in their 20s, which unfortunately more and more do now, then this might be a reasonable test to do in their 30s. Bad family history. I have patients, oh, everybody in my family died by age 40. I'm not gonna say, well, you have to wait till 40 to be tested. And if you're still alive, I'll do a heart scan on you. So I do sometimes, with the extreme family history or with the crazy LDLs, the LDLs of 190 and 200, I will test them earlier. But anybody at my center who's under the age of 40 who wants a scan, even though they can pay cash for it, I have to approve it before they can get a scan. I really don't want the worried well. The 20-year-olds whose dad had a heart attack at age 60, getting scanned just to prove that they don't have anything at age 20, because that's not going to be very informative, and I'm going to be irradiating people unnecessarily. We want to make sure that we don't take these people and rush them to the cath lab. And there's still some very little, I'd say now in general, but still a little confusion on doctors' parts on what to do with a calcium score. And we're working with the RightCare initiative to try to create a treatment card to help direct what to do with these scans so that doctors in the trenches, the primary care doctors, know a little bit more about what to do. But these are built into our guidelines already. I showed you the cholesterol guidelines. There's also in 2019 the prevention guidelines written by the American College of Cardiology and American Heart Association, and they say we should be more aggressive with blood pressure, aspirin, and cholesterol therapy in those patients who have an elevated score. So I think we're getting more and more treatment algorithms, but we don't want to rush people to the invasive cath lab every time we see a speck of calcium in the coronaries. It doesn't mean they have a blockage. It means they have early plaque building up. Right? You don't need to redo all your pipes the first time you get a little clog at home. But if it becomes a big problem, you may need to do something more aggressive. So I'll leave you with this concept. This is from 5,000 years ago. I've had people tell me that they've had this read by people who are more fluent in Chinese than I am, because I only know the food products from the Chinese menu. But it does translate here pretty well. This is from 2600 BC. So this is almost 5,000 years ago. These are the ancient Chinese. Superior doctors prevent the disease. Mediocre doctors treat the disease before it becomes evident. So that's what we call subclinical atherosclerosis, and that's where coronary calcium begins. So I can be a mediocre doctor in the eyes of the ancient Chinese. But I'm better than this group who treat the full-blown disease, and we're still doing this a lot. We wait for the chest pain. We wait for the heart attack. We wait for the stroke to start these therapies, and that's terrible. And if you don't think this is still happening, then, and I don't want to get political, but Bill Clinton is a good example. 8 years in the White House, 8 years of being told he's doing great, he has no problem. They stopped his statin because he was doing so well, because he was running and losing weight. He, a few months after he left the White House, he had a calcium score that was over 1,000, so astronomically high. Was started on treatments, and then months later had chest pain and went for an angiogram and needed multi-vessel bypass surgery. So I don't know if that was a Republican doctor taking care of him when he was in the White House, not getting him a calcium score, but I can tell you that, going more with my conspiracy theory, almost the day after Clinton got his bypass, they added calcium scoring to the presidential algorithm of care, the executive physical, and George Bush underwent a calcium score as part of his executive physical. And every year, and every president since then has gotten calcium scoring, Obama, Trump, and others. It's changed our algorithm of care at the very top, and I'm hoping it trickles down to the rest. So I'll leave you with this. If you're interested in data, this is a wonderful, wonderful documentary. It's on YouTube. It's on Google Play. It's on all the different groups, Prime and you have it on the website. It's a documentary. It's about 2 hours long. It's a full-length documentary, starting with the calcium score when it was first invented in 1989 in San Francisco, and moving through its evolution, and has people who are both pro and con. If you're watching it early on and you see Harrison Ford instead of me, you're watching the wrong Widowmaker. Harrison Ford made another movie called Widowmaker that's about climbing K2. So if you're all of a sudden see Harrison Ford, then it's still a good movie. I would recommend you finish it, but you'll have to try again to search for the right Widowmaker. I don't know if you don't have both Widowmakers on RightCare. You only have this one.
I just have the short.
Okay,
Widowmaker.
but there is a 2-hour documentary that you can get onto.
By the Irish Heart Awareness Foundation.
Yep.
So that's really important that it's not a commercial thing.
Right, and he did have pro and con. He does have some people who really don't like the calcium score and think that it's not the right test on there as well. It's definitely, he has a very wide array of different people who are both pro and con. It's not just a promotion or an advertisement to get a calcium score, and it does go through a lot of the science as well. And you'll hear some of the objections and see if how you think that they portray. So it is another opportunity to learn a little more. So I'll stop at this point and thank everybody. And I know you have Bob coming up next. So
We have about 20 minutes.
okay. The green light's still on, so at least the Q&A will be recorded.
Comment on plaque rupture and non-calcified versus calcified plaques. And then the second question is in the serial testing. Sort of mentioned it for the zeros and check them afterwards. But for people who are positive, do you also do some serial testing, and how does that affect what you do, and statins influence that in addition to aging?
Right. So the first question is about, which plaque is going to rupture. And calcium, I always remind people, the calcium score does not identify the vulnerable plaque. It's not going to tell us that plaque halfway down your left artery is going to rupture and cause a heart attack. It identifies the vulnerable patient. The patient with a lot of coronary calcium has had a lot of plaque ruptures in the past. Calcium is kind of a healing process. So if you have a lot of calcium, you've had a lot of plaque ruptures, and who's at risk of another plaque rupture? Somebody who's had a whole bunch of them. If you've had 0 plaque ruptures in your life, your risk is very low. So the calcium score identifies the vulnerable patient, not the vulnerable plaque. The vulnerable plaque is probably a lot more complex, and we're still pursuing that academically to try to figure out which plaque may be the next one to go. The second question was about repeat testing, and I talked about my predilection if the score is 0 and ACC recommendation, the American Heart Association recommendation, to get another one 5 years down the road to reassess risk. I think that's prudent. I wouldn't wait 10 years unless it's a very young person. I get nervous that things break down. I always tell my patients that your warranty is gone after age 50 and things start breaking down quicker. and blood pressures go up, glucose goes up, you develop diabetes, your cholesterol gets worse, everything kind of goes haywire. So I don't want to wait 10 years and see if something bad has happened. So I wait 5. For a positive score, I wait at least 2 years, but I find some value in patients who are not getting everything. I talked about some of the other therapies that we can apply. Some patients don't want to go on 80 milligrams of atorvastatin. It sounds like too high a dose, and they only want to take 10, or they take 5 every other day, or something like that. So some of these patients I'll retest and say, you know what? Your plaque is still getting worse. You're developing new lesions, which means you've had some small plaque ruptures along the road, and I want you to be on more aggressive therapy. It also helps me with the non-statin therapies. If I see somebody progressing, who am I going to use those more expensive PCSK9s, or maybe Vasipa, or maybe some of these new diabetic agents that are injectable that might have some great value for coronary disease? I'm going to need to document that they're progressing. So I do use it sometimes. If they're already getting everything and they're doing great, I don't repeat the test, because if it's not going to change my management, I don't get any test, including a calcium score. So I don't think it's a mandatory thing. It's not an annual thing. Just like I think, well, it's probably not a great example. I was going to use the mammogram example again, but women can get new breast cancer down the road. But once you have breast cancer and you're being actively treated for it, you probably don't need to be screened for breast cancer again. You probably need a different type of test, more of a diagnostic test than a screening test. So I stopped screening them once I have the diagnosis. If they've had a heart attack, obviously I'm not going to get a calcium score again, because that's not informative. Right. Yeah, that might be a little overstated. 1 to 10 may actually play out. Let me show you a different slide here that I didn't show before. 1 to 10 may actually play out very similar to a 0. This is your risk as far as in black is a line for calcium score of 0, and yellow is a slide for 1 to 10. And you can see the event rates were identical. So I think when you're below 10 in the single digits, it could be noise. It could just be a mistake of the read. You get a little speck of noise, and I can't tell if that's plaque or not, or you have so little that it doesn't cause any trouble over the next decade. So I think you're probably right. We break it down usually 10 and up, but most of the publications, 0, 1 to 100, 100 to 300, and then greater than 300 are just the categories that we've used. It's probably not perfect, but there is a difference. And if you looked at the MESA data, I looked at patients with 1 to 10, and there is a little bit of increased risk over time. It didn't show up in this paper, but there is probably a little bit of increased risk, but it's pretty nominal. So I would treat less than 10 much more like a 0 than like a positive number. It's double digits, you've got plaque. You can't get that much noise that we're going to score it at 12 or 15 or 20. And it's not my eyeball, it's a computer coming up with an exact number. So I'd say once you're in the double digits, you're safely, you have atherosclerosis. The more the score, the more atherosclerosis you have. But it's a great question. Sure. Yeah. We've seen low scores be more malleable, and that might be just in finding it at an earlier stage. Calcium is probably not absolutely yes, no. There are densities of calcium, and there can be very fresh lesions that may be a little more amenable to change. So we've seen some lower scores more amenable. Once you have a very high score, it's there, and you're going to, but in general, we'd say no, there's not that much movement. In general, we'd like to see it plateau. If you had a score of 150, I don't want to see you having a score of 500 in 3 years or 1,000 in 7 years. I don't want to see it keep going up. I'd like it to still be in that 100 range. And there is a little error of the test. It's not the scoring error. The scoring is very consistent. If I were to score it, if somebody else were to come up with a score, it would almost be identical, because I don't eyeball it and say, oh, that looks like a 12 in the LAD, and that's a 7 in the circumflex. You have a score of 19. The computer does it, so it's very reproducible. But when you rescan somebody, even minutes later, if you take them off the table and put them back on, the position of their body relative to the scanner may be slightly different, and it may show up a little bit off. So there's a little bit of error in scanning. So small changes, going from 100 down to 90 or something like that, within 10% may be part of the error of their test. But 100 will not go to 0 ever. That's one of those two tests is incorrect. If you went from 100 to 0, somebody made a mistake scoring one of those two scans. One of them is wrong. That's impossible. Please.
Address maybe some women's issues who are around calcium replacements for osteoporosis prevention and whatever, and some fear that might.
Yeah, so that's an important one. So the question is about calcium supplements and osteoporosis treatments. And I can tell you calcium in the diet, unfortunately this is calcification or calcium we call it, so it gets confusing. But your bone has an incredible ability to absorb and buffer calcium in your diet. So it absorbs over 99.9% of the dietary calcium, and it'll put it into the bone. So taking more calcium will not go to the coronary arteries, it will go to the bone. But if your kidneys fail and your kidneys are not working, then you have what we call a metabolic bone disease. Your bones, because of different hormones, can no longer absorb calcium. They tend to get extensive calcification. So as long as your kidneys are working relatively well, calcium intake has nothing to do with calcification in the coronary arteries. For dialysis patients, calcium intake is directly linked to calcium in the coronary arteries in a very strong way. So you need that healthy bone, but if you have just osteoporosis and you're taking a lot of calcium supplements, I don't care what your calcium score is, you should take a lot of calcium supplements if that's what your doctor who's taking care of your osteoporosis recommends. If you have dialysis, we avoid calcium supplements in those patients on dialysis, and we give them other ways of buffering their phosphate and treating their bone disease. Please. Uh-huh. So, yeah. So in 2018, these guidelines, November 2018, these guidelines came out, and they put calcium scoring in the algorithm of treatment. And we've met with some of the national payors, and they claim that because now they're in the guidelines, that they don't want their reviewers who are taking these phone calls from doctors to be in opposition to the guidelines. So if you have somebody who fits, that they should say yes, because that's guideline directed care, versus saying no. But we have not seen national policies change yet, even though I spoke to somebody from Blue Shield right after these came out, and they said that they were going to be changing their policy. That has not yet happened, and it's been about a year. Medicare, in certain states, it's all based on local coverage decisions. In Medicare, in certain states, not national coverage for calcium scoring is covered in about 14 states, but those are local coverage decisions and not the all Medicare patients. So it depends on where you live and who the intermediary is for Medicare. And some insurance companies have claimed that they do cover it because the societies now are going to these, and Aetna and United claim that they do cover calcium scoring already, but we've not been able to affect very good reimbursement or consistent approvals from them. So either those policies are not well out there, or doctors are not calling up giving the right yes, no to the algorithm to get to a yes, which is, you have to learn the algorithms. Blues in general do not cover it. And we heard from Kaiser just a few days ago, they do offer the test, but they don't use it widely, at least Northern California, and that's different than Southern California, but they do use the test, but they don't advocate it very widely yet. So they're still learning how to implement it. So all of this is still relatively new. It's less than a year old. So not to put too much onus on any one company, but I do think that the evidence base is favorable. Now, the problem we have is U.S. preventive task forces, which asked a different question about 2 years ago and got a different answer. They said, should everybody get a calcium score? And they said the evidence is insufficient. And I was one of the reviewers for it, and I mean, I would argue the answer should probably be no, that if you ask that question, we don't need it to be everybody, we need it for intermediate risk. And they didn't really ask that question in that way. So I don't think, so people say, well, U.S. Preventive Task Forces doesn't say yes, but they also don't say no. They said indeterminate, and I think they just asked the wrong question. When they're going to ask the correct question, I'm not sure, but I think that there is a lot of evidence. I could have lectured for 6 or 8 hours. Honestly, there's 1,000 at least publications on coronary calcium scoring with outcome studies, different populations, and new ones coming out all the time. There's a new one on compliance that just came out of, that's very much like the Eisner study that shows that patients who saw a calcium score were much more likely to take cholesterol meds and blood pressure pills and behave better and lose weight and exercise. So we have a lot of evidence, but we're still trying to get that in the hands of the payors.
Could you just mention what the military and NASA, the astronauts have done with this testing, how they were involved with the development?
Yeah, so, Air Force the Air Force is been using this test since about 1989 or 1990, almost since it was invented. They've been using it before any group ever. Because they didn't want their planes up there with a single pilot and that pilot having an MI and crashing their expensive plane, or maybe be nice and maybe they cared more about the pilot than the plane. I don't know what their underlying motivation was, hopefully the pilot, but they didn't want these planes crashing out of the sky because somebody had a heart attack. So they've been grounding pilots and using it in their risk assessment for a long time. About 2 years ago, I got involved in a group working with NASA, because NASA's talking now about doing extended missions to Mars and other long distance trips, and the door to balloon time, the time that it would take to get them from, and they have this calculated, if they're at the space station, if they have a heart attack, it takes 28 hours to get them back to Earth. So that would be a long time to be going through a heart attack before we can get them to a hospital in Frankfurt, Germany. They would have to land somewhere in the Eastern Europe and then be transported to Frankfurt, and they have it all worked out. It's 28 hours on average. So they use it now so that they don't send up astronauts into space, or even now, we started using it to identify astronauts who shouldn't be put into the program, because it takes them 10 to 20 years to develop an astronaut, and they don't want to invest for 20 years to then find out the astronaut needs a stent or has a heart attack and is not healthy enough to now finally go into space after spending whatever that investment is. So we're using it in the astronauts in NASA, and the Air Force has been actively using it for a long, long time. So I think that we have seen some uptake in specific groups, but not in the most widespread way yet that we'd like to see it used appropriately.
And can you just mention the cost savings with LA County Fire?
So LA County Fire, we use it, and we've been using it for probably about 15 years now, maybe definitely over a decade with LA County Fire, and their cost savings is in the millions from using a calcium score. They use it a little differently. What they're trying to do is identify patients who have a positive treadmill or have high risk factors, and specifically scan those people to show that they don't have a problem so that they can go back to work, or that they do have a problem and to get them the treatment that they need before they go back to work. And it's worked perfectly. We haven't had a heart attack among our patients who've been scanned with a score of 0 in over a decade. They continue to renew our agreement, and their firefighters in LA City is now using it as well. So we're using it for both LA City and LA County, and Downey Fire and a few other groups are using it. But the concept is that if they have a score of 0, they're fine. If they have a positive score, now they've already had a positive treadmill or very high risk, we'll do a non-invasive angio to see if they have blockages, and then get them a stent or bypass or whatever appropriate treatment. And we have some that we just put on aggressive therapy. We had a firefighter I read this morning, I was reading cases, has a calcium score of 1,500. So he's not on a statin, he's not on an aspirin, he's, when the questions are asked, do you have these problems? He says, I don't know is how he answered the questionnaire. He's not on any treatment and he's very, very high risk. So he's going to be able to continue to work. But part of my job is to call him and get him in to see his doctor and get him on appropriate therapies to prevent any problem down the road. And the fire department's so happy with this program that they incentivize the firefighters now to go through with it. So they get paid extra to get a calcium score. So it costs the fire department both to pay me and to pay the firemen to get the test. And they still are doing it more than ever before because they perceive the benefits among their population. And firefighters are at a unique group because if they have a heart attack, the average loss of as far as wages and utility is about $2 million per firefighter. So if they have a heart attack and they have to get benched and they have to do desk duty for the rest of their career, it costs the fire department about $2 million on average. So they have a much more aggressive approach because they have a much bigger piece of the pie to save if we can avoid heart attacks in that group, just like the astronauts. Or maybe the Air Force.
One of the slides that we have in our booklet that I put at each of your desks is, this was printed by the California Department of Public Health. They said we need to get your work more out there. And one of the graphs that is from your work is this Fournier trial. Page 6. So this is about the risk being higher for people with scores over 1,000 than those who've already had heart attacks and strokes. Can you just talk about that a little bit?
Yeah, let me take a look. I don't know this one. Yeah, that's interesting. All right, so this is this was a I'm involved in that paper, but this is a Hopkins group. I think it's similar to what we showed you before, where the patients who had a positive calcium score were just much more likely to have cardiovascular events. I don't know if there's anything, I don't know if I'm missing something, Hattie, if there's something more. This is the same as that extensive calcium score, I think.
Well, I think it's just really big news for our group that if somebody has a score over 1,000, that risk is actually higher than somebody who's had a heart attack.
Yes, yeah. So yes, and we've looked at that with so we have we've shown now we have a paper coming out that patients who have a score above a 300 are at secondary risk equivalent. In other words, they have the same risk as if they've already suffered an MI, even if they haven't yet had a heart attack. So 300 is where you become secondary prevention and where your risk goes up a lot. This is another evidence of that, looking at patients who suffered a heart attack in the 4-year trial versus calcium scores. Please. Right. It's a 2A recommendation. Right. It's a 2A recommendation. Yep.
Let me ask you from the standpoint of a patient who has now, I've advocated among my colleagues, my family, my friends, and it has really been life-changing information. What I don't understand is why would you take a statistical clarity like this that costs really Medicare paying $98 for it? Why wouldn't you want to have this information, especially when it's cost saving and of course life saving? Life saving. Let's go with life saving.
And National is looking at it now based on some of the working with the science, but it hasn't changed yet. Absolutely. And I just want to point out we asked a lot of the different societies. We're working now to try to work with these different national payers on a national scale to show them the evidence and maybe try to well define an exact population that could be administered and deal with all of these algorithms of care that are very complicated. And the National Lipid Association didn't want to sign off on the test. And I'm like, why wouldn't you, or sign off on our request to get it covered? And they go, well, we already get it so readily and it's so inexpensive that they're worried about the opposite. They're worried that the Blues will cover it, or somebody else will cover it, and the reimbursement will be so low that people don't want to do the test anymore, that the radiology groups won't want to perform the test because they're only going to get $29 or $39 or whatever number it is. So it's very interesting, just the different perspectives that you get, but they're very nervous that it's going to mess up their coverage, and they're not having a problem, they said, in getting it in a lot of these places around the country, or getting it for radiology groups will do it for $79 or $100, and patients can pay out of pocket and get it covered. So I'm not saying that that's a great solution, because there is a natural barrier. If a patient knows that it's not a covered test, then maybe there's something wrong with the test, or maybe the test isn't validated, or maybe the test isn't, there's a reason why it's not being covered different than the science. And that poses a bit of a hesitancy on some patients. And of course, not everybody can afford an extra $100 to get the test. So I think, our goal will be to work with payers to try to find a very well-defined pathway that can get it covered at a reasonable cost to both groups, so that it's in the Medicare range, so you're not paying 4 times as much, which you often get stuck doing for other tests, or the radiology groups getting 4 times less and not being able to afford to do the test either. So it's just funny how the juggling act from different sides of the coin make it more challenging. I do think it's helpful as a clinician, and I do think it can be delivered at a very inexpensive cost compared to some of our other tests that we currently offer. And I know as we do more healthcare economics that it will save money to healthcare, because once you have a score of 0, there's no justification to do a stress nuclear, which is still, I think, grossly over reimbursed by the insurance companies and paid way too much, and the radiation and everything else that goes along with it. So I think we can cut down on downstream testing, which we've been able to show in multiple cohorts, but I think that'll help us get it on balance with some of these other concerns of cost. Please. Right. But I think we can develop algorithms that the HA and ACC would sign off on that says if you have a score of 0, you should not get a nuclear, and then you could probably deny it based on that as well. Yeah. So I'm just saying, I think it might go both ways. We'll try, and I'll be glad to help bring some of the national thought leaders into play if we can. And I know ACC and HA are behind the test, but we need to roll it out in a reasonable way for everybody. And you can see how complicated it is just to not just say, okay, let's start covering it tomorrow.
So Angelo Jambroni has a question, and then I have a question.
Yeah, my question was, I think one of your slides actually showed a reduction in cost.
Yes, we did show a reduction in cost in the Eisner study, which is, and I think part of that is the nuclear, because Cedars-Sinai is our focal spot in the world for probably, for good. Dan Berman's a very famous nuclear cardiologist, but I think a lot of this cost savings comes from reduction in downstream testing, especially nuclear cardiology.
It's important evidence, and it does make a difference.
Yes, and it can save costs if administered properly. And that requires a lot of education. And that's something that we're working very closely with Hattie on, to make sure that the primary care doctors know what to do with a 0, but also know what to do with a high score and not panic and get them into the hospital for $1 million workup either. We got to balance all of that.
So I know that you're supposed to repeat this, and it's kind of a long thought. So in the California data, there are, for people less than 65 years old, the latest data says that there were about 65,000 strokes less than age 65, and about 35,000 heart
Yeah, so the question is about these younger patients under age 65, the pre-Medicare populations. Those are the ones that are going to be captured by a lot of the PPOs and different payers, HMOs. How many of those 65,000 strokes or 35,000 heart attacks could we prevent with a calcium score? And I think we have some good data from the St. Francis group that says that probably about 40% event reduction is what we would expect. If we could get this, now obviously it's not going to be quite that many because some people are never going to get tested, and some of those less than 65 are going to be very low risk and they wouldn't qualify for a scan. So we're always going to miss some. But I think of the higher risk population, we should be able to knock that down for those who get scanned by 40%. And that's based on the randomized double-blind trial, not on just a guesstimate, but it still needs to be vetted. Let me turn over to Bob. We're running out of time here. I know he has some slides to show as well. Thank you very much.
That was very informative. I think we were all more elucidated now. Thank you so much for that. The next topic that we're going to get into here is updates from the front lines, in a Heartbeat Silicon Valley pilot study. Victoria Dupuy, who is the executive director for No More Broken Hearts, and I think some of you have met her before. She couldn't come today, so Bob, it's on your shoulders to do a stellar job here. Bob Trine he's actually now one of our regional directors for the California RightCare Initiative and the LA University of Best Practices, so we welcome him for that. But he's also founder and CEO of Trinomics, which is his own company. He has a lot of experience in the last 2 decades in healthcare consulting from various stakeholders in the business, and so he comes with the background that is well served to really look at this from multiple angles. So Bob, take it away.
Thanks, Carol. And thanks, Hattie. This study came about originally from a lunch that Hattie arranged about 2.5 years ago now in Silicon Valley, where I met Victoria. And Victoria, for her personal reasons, her husband had died suddenly from asymptomatic heart disease at 46. An executive at Apple in the executive health program had just cleared his physicals and dropped dead. And on my side, I've been lucky. In fact, since we've been doing this, we've had 5 of our adult family members get a CAC score. And it's mixed race, so it's African American and it's white. And out of the 5 of us, we've got 4 zeros and 1 2. And you wouldn't have expected that, based upon, various things. But so I haven't had the personal issue, but I've seen the numbers, from the CDC and elsewhere in terms of the numbers of people with asymptomatic heart disease, the heart attacks, which are unexpected, half of them resulting in death. And it just has seemed to me that we ought to be able to do a better job. And so Victoria and I put our heads together, and we were thinking that in order to do this, we want to take advantage of a few things, of Victoria's being able to go to the community and get involved, the ability from a mobile perspective to take the CT scan into the community, whether that's an employer group or whether that's an underserved community. And from a process perspective, take advantage of things that already exist, whether that's a corporate wellness program, which we used, or Dr. Budoff's lab to read the scans, which is the way that we did it. So we wound up doing a study. We did the field work in June at the Mountain View Center for the Performing Arts. I drove this bus up into the backstage area for 3 days, and also at the Campbell Community Center for another 3 days. And so thanks to everyone for making that happen. So our goals, we had public health goals, obviously, to support prevention objectives and improve early detection, right, and get people into treatment. We had some operational issues. This is more from a business perspective. Wanted to use sort of standard or high quality but available corporate wellness programs because they're out there in the marketplace. They're not providing as much value as they probably could. There was a particular organization I was familiar with that has gotten some awards and has been doing some pretty good work, so we used them. We wanted to do, see what we could get out of a finger stick, something that somebody could do at home. Basically, just a drop or two of blood. What could we get out of that? The mobile CT scan, of course. And then one unique capability, which is polygenic risk score that we actually brought in from Cambridge in the UK and Baker Heart and Diabetes in Australia, which was one of two labs really. Broad is the other one that's been doing some high-end work with polygenic risk scoring for heart disease and others. So we use that strictly on a research basis. And then we have, so there's the public health, there's the operations, and then there's the research. We're actually just completing that work now. We'll see a little bit of that here today. So here's a look at it. You know, it does take a village in this case. It doesn't necessarily take that much to make it happen. You know, if you're an organization with whether it's a health plan, with a wellness program or a provider. But for us, we had to piece it all together. LA Biomed, or now Lundquist Institute, participated throughout, including on-site in terms of working with the participants as they came in terms of reading the scans, in terms of doing the research. So thanks to everyone, that middle bar there, we, after going through the scan, getting it read, and getting the results back from the blood work, then we did contact all of the participants, because the other thing is, so what do people do about it, right, once they even know? And so we had multiple contacts with them to make sure that if they had risk from any of the risk factors, that we would encourage them to go back into their provider, whoever that might be. And we had arrangements with top quality preventive cardiology groups at UCSF and Stanford to take care of higher risk patients. Georgia Tech did the analytics from a genomics perspective, and Lundquist, now Lundquist, is putting it all together. So the study metrics. So we accepted anyone over 40 with at least one risk factor. So not exactly intermediate risk, sort of mild, but at least one risk factor. And we wound up with 104 participants. So we got a few more than the 100 that we were looking for. And of those, 37%, so 39 of them, had a positive CAC score. And so that was with a fairly minimal effort, right? We got it up to that point. That's 2.7 needed to screen. I understand from the Cardiology study, they suggested that there's sort of a hypothetical 2.2 sort of best case. So we were able to get pretty close to that with just age and a risk factor. So not that difficult, really. And then participants also took a health risk assessment that occurred afterwards because there was some logic built into it, and so needed to know the blood work. And of those, we were able to calculate the 10-year risk score for 46, and 9 of them were in the intermediate, so 18%. So just a little bit more on that. So basically, of those 39, a third of them, or 13, had a CAC score greater than 100. And as Victoria has continued, that 13% of the total screened has remained pretty consistent in terms of finding people with CAC scores greater than 100. That's pretty meaningful to me. I mean, that seems like we're finding a reasonable amount of people in that, and 3 or 4% have been coming in over 400. So without, like I say, a lot of discrimination, we've been finding a CAC out there, so basically asymptomatic. If you look at it from a risk perspective, so there are these percentiles, and 75 percentile being a key one. For those aged under 50, we had 4 with positive CAC scores, and of those 4, 3 of them had a overall risk score of 75% because they're younger. That's going to take, the lifetime to develop. This was interesting to me to see how this played out, that for those 50 to 65, we had 8 over 100, 1 over 400, and about 10 over 75%. So you see how that age has an impact on that overall risk score. And for those over 65, we had 2 over 400, and we had 2 over 75%. From the CVD perspective, so we were able to calculate off 46, and of those, 18% were in that intermediate between 5 and 20%. So again, that can be a relatively inexpensive thing, because we actually did this after, because it wasn't part of our original design, but we happened to collect all the data needed. So just last week, we ran these numbers, and the data was in what we had collected from the wellness program, and on that day, and we were able to calculate it. And so on an ongoing basis, Victoria continues to do this. She's been working with community centers, fire departments, a couple of business locations. Again, holding that line at around 40. They've done 11 additional screening days, and with an additional 257 participants. And they're consistently finding about a third of the people that they screen do have a positive CAC score. And then more on the research front, this is what we're doing with Trinomics. We have relationships with preventive cardiology groups, really from Boston to Oregon and down to Atlanta and up to the Carolinas, of preventive cardiologists that are interested in using polygenic risk scores primarily as a motivational tool. Because it's DNA based, you can do it at birth theoretically, but it's the first look at risk. And so we've been doing various things with that not just direct to the consumer, but within the confines of preventive cardiology. And we're also working with what we call a multi-omic triangulation study with UCSF and Georgia Tech, where we're looking at the molecular processes involved with heart disease, whether those are DNA, RNA, influx, which is the deposit of fatty acids into the body and into the arteries, or efflux, which is the removal back out again, or inflammatory factors. We've got the project designed, and we're in the sort of the funding phase of that particular effort. And that's, so the idea of this segment, we're trying it out to see, and I want to encourage all of you, if you're doing a program that you think is having some success, getting the job done wherever you are, whether that's in the provider group or a payer group or a special interest group of some sort, we'd like to open up the schedule to allow for people to talk about that, and just kind of like more frontline, practical, getting it done type stuff. And that's it. Yeah, just a segment, like 10, 15 minutes, right? Right. So any questions or comments or for either on this or the other? Yeah, go ahead, Scott. Right. It was pretty consistent with the study. It's been around 13% at 100 or over. Oh, 0 to 9. Oh, yeah, I do have the number. Actually, I don't have the number with me on the follow-up score. I don't know, because I haven't been tracking Victoria's numbers on that, but I can ask her about that and see. Yeah.
But if you found 32% were positive,
Mm-hmm.
and 13% of those
Mm-hmm. Over 400, right? Over 100, right? And 3 or 4 over 400.
So then you just go 32% minus 13%. That's less than 100.
All right. I'll check with her and get back to you on it.
So
Yes, Carol.
when you get the results of the quote positives, your interaction with the folks that are taking the test, do they know up front that if they get a positive result, they should see their doctor? How do you inform them on further steps?
For the study, and I have to differentiate it. For the study, we had multiple contacts, and so they would be contacted by Dr. Budoff's team, relating to the CAC score and be informed about it, just handle questions over the phone. And then also if something came up in the blood work or in the risk, out of the risk assessment, then they would be contacted from a health coach from the wellness company, and they would talk through that. Basically encouraged where appropriate to go to their physician, right? And help them if they had some problem with that. Yeah, well, it's something to think about. I mean, there are, mobility. I mean, there are a lot of underserved communities, number one. Somebody's got to pay for it. But there are, our thought too was for Silicon Valley, where they do a lot of things for their employees on a Friday afternoon, right? So there's, there are different ways to skin the cat. Yeah.
Was it an employer who partnered and said, we'll take on the cost of the test?
It was Victoria and her not-for-profit. And yeah, we did do a little bit of crowdfunding for it.
The widow has done major fundraising events in Silicon Valley, raised the money to create the mobile unit, buy the heart CT scan, work with the regulators in the state of California, and it's just up and running in the last couple of months. And I heard phenomenal life-saving stories.
Yeah, a lot of anecdotal evidence, if you will. Yes, Keith.
What does it take to get on the schedule to have your bus come by?
Well, right now it's, because of gas and mileage and all that, it's primarily serving the Northern California marketplace. So you'd have to kind of go to it. But, and so I can give you Victoria's email and she will let you know. And she will make sure you're there. Right.
We're doing like all these different health fairs like every other month now in different areas. So just wondering if I can coordinate that with my members that state.
Sure. So Victoria is a great first step. And then, of course, the operator for commercial purposes, or if it's not something Victoria's doing, they've got their own, because they do mammography, so they're connected to corporations and are active in that arena. But no, they can sort that through with you. That was the idea.
I'm gonna sponge drink here. Can I just elaborate on that a little bit? Because there have been a lot of demands. People at the state capitol, when they heard Dr. Budoff's presentation on Monday, they said, we want this to be mandatory CME for the state, or we want to boost the CME to have online CME available. We want to get letters out through the medical board, et cetera, about these new guidelines. And we want to get the mobile unit up here. If I talk to Victoria, who was at our Capital Region University Best Practices on Monday with Dr. Budoff, and she said that she has so much more demand than one mobile unit can support. So this is something that maybe some people in the room could help build, more. One in this community, she said she's trying to get her own, where she's not working with partners, because that same company that staffs it is also doing mammography events. So she said to build a new one would cost about $500,000.
Yes.
Can you just say who you are too?
Yes, Colleen Clinton McBride from Health Net. And this might actually be a question more for Dr. Budoff, but I'm wondering how well do providers know to use this information? What, like if we're promoting the test, is it general knowledge for providers? I mean, is it really an effort of disseminating the guidelines? Is that where?
As far as what to do with the results?
Yeah.
Well, I mean, most of the testing places have an algorithm and they say your score is this, these are the recommendations.
Okay.
So it doesn't just, you don't just get the number and walk away.
Okay.
They come with recommendations, and Hattie's working on a little card to help them as well. They wanted something like that for additional information, but I think it's not complicated. Score of 0, healthy lifestyle, high score, be more aggressive.
So if somebody actually got one of these tests at one of these vans and went to their PCP and said, hey, I got this, they would actually know.
Yeah, to be like the whole second page is all like, this is your score and this is what generally recommendations say you should be done. So those guidelines come with the test. So it's not just a.
And you think they would actually embrace it and it wouldn't be some inertia to sort of continue to give a statin?
We've had pretty good uptake. I mean, in Southern California, we've been doing it for a long time, and we allow people to come in for screening on their own, because it's, depending on their coverage, and we haven't had too much pushback of doctors. Every now and then, they're saying, I don't use that test, but write an order, so I'm not responsible for it or something. I think most of them are a little more caring, and patients use it as a leverage to choose doctors.
I think there is a risk of there's an issue of clinical inertia that we as a community need to put our heads together around overcoming. Because when the test was first used by the military and the astronauts way back when, it was higher radiation and it was very expensive. Now it's the same radiation as the mammogram. It's, less than $100, and it gives you such important information. I think what the California Department of Public Health got so excited about is that slide that Dr. Budoff showed about all-cause mortality and even cancer mortality, which I don't know if anybody has any insights on what that cancer thing would be about, but it's really, I think it's that we need to reframe it as a triage tool. So maybe some of the payers in the room could work with us and others, big systems also, on how do we create practical materials like we did with the hypertension pocket card that can guide who should get the scan and what should be done with it. So I did bring several cardiologists together at the Capitol on Monday to get that started. And Dr. Balmer from UC Davis said he thinks he can get it done in 20 minutes. So, but what I heard in the conversation sounded a little bit more cacophonious than a 20-minute resolution. But Scott, would you volunteer to join our group? Sure.
It was easy.
Carol, will you do it? I can try. Okay, and then Earl, is this something that's interesting to you at the VA? All right.
So one more thank you I wanted to do just for promotion and branding, and without whom this would not have happened. I want to recognize my wife back by the door there, Lynn, for In a Heartbeat and other promotion.
All right.